we have about 15 minutes for Q&A. So my first question is actually to you, Jan. Thinking about Alana's talk, she talked about the differences in the cost of housing versus the cost of upkeep. And I know from some of my work and just reading is that one of the issues with rural hospitals is you tend to have higher fixed costs for low volumes, and that is, I think, part of the problem in keeping them open. But I'm trying to think of like the implications of what you're advocating for. Maybe you're not advocating; you're just saying this is the way you could do it.
I'm totally advocating.
Yeah, is this like subsidies or enhanced payments? Because in primary care, we talk about. Okay, I'll be quiet and let you talk. Okay.
I'm sorry. That was at the concept of it is enhanced payments, but thinking about them differently. For example, the problems that affect rural healthcare also affect rural schools. Unfortunately for schools, every state's constitution requires that education be provided, so that it is usually a mixture of local funds supplemented by state funds, because otherwise rural schools would not be there. The problem that you just described, Dr. Peterson, for rural hospitals, that because you have a smaller patient population that to support a facility of N size, and it has to be N size to be a hospital, you have greater per capita costs. You have the same problem with rural schools, and we have figured out that we can do that as a utility. One of the things it is not cost effective to run electric wires in Loving County, Texas, but we do it. Another thing I like about the utility model is that right now we have no control over where hospitals are. If they want to leave, they can. But the electric company is not allowed to leave and decide that they're not going to serve your entire county, because they are a regulated utility. I think we need a little bit more control over what is in our communities rather than what is in our people. And enhanced payment may be one mechanism, but there may be others. I want us to start thinking differently and more broadly, because if we keep going down the same trap, we're doomed.
Just one quick follow-up, and then I got a question for Alana, and then I'll take an audience question. So as you were talking about infrastructure, and I was thinking about roads, one of the issues, if it did go up to a state funding and state planning, is oftentimes, then that means the state is allocating resources, and they might allocate them to larger population centers. And even though there is a road in a rural area, it might not be as well maintained as the urban roads. And how do you think that would work?
Yeah. I used to live in northern DC, Northern Virginia area, where we always complained that the legislators spent all the money in Richmond and not up where we needed roads. That is a common problem, but you have at least you have a political process by which it can be addressed. When you are talking private equity capital running physician practices and hospitals, you got nobody.
Okay. True. All right. Alana, I have a question for you, and then I'll get to audience questions. I actually still get my hometown newspaper. In the last couple of weeks, we had a gubernatorial debate there, and they covered that. And one of the local leaders said that the biggest export our town had was our youth. And some of the data you present went to that, to kind of out-migration of youth and the concentration of larger percentages of older adults in rural areas. You've mentioned that this poses opportunities and challenges. Can you say more about what those are in terms of the context of your talk and health in rural America?
Certainly. One of the challenges that I've seen in some of these communities that have a high proportion of older adults is that there is not an adequate workforce to be able to support the needs of that population. And I'll give you one example. As you know, I'm from Frontier, North Dakota, and I visited one rural hospital that also had a nursing home, and they ended up closing the entire wing of a nursing home, not because they didn't have people who wanted to live there. They had plenty of residents in the queue, but they could not find an adequate workforce of CNAs and LPNs to be able to adequately staff it. So when you look at the disproportionate number of workers in a community and the needs of older adults, that gets to be a real challenge. On the other side of the coin, I think there are also real opportunities. there's phenomenal opportunities to look at intergenerational kinds of settings. And we have been looking at some really interesting retirement destination places where they are integrating people across the age spectrum, particularly people that are in, for example, healthcare training programs. Instead of having an apartment somewhere else, they are looking at co-locating them so that there's an opportunity to do some multi-generational learning and exchange. And so I think in rural communities, we need to look at this as an opportunity and not solely focus on the deficits, because our older Americans, particularly I think our older adults, have so much to share and can contribute so much to the fabric of the community that I think we need to look for more and more opportunities to make those kinds of connections.
Okay, that's great. So one of the questions I had, but also an audience member did ask us a very similar question. Might be more for Jan, but feel free to answer too, Alana. Was the idea about, we brought up the example of the diabetes self-education classes and the lack of availability of those in rural areas. And for the infrastructure piece about people telecommuting, which Alana brought up, there might be a change in people living in rural areas because telecommuting. One audience member asked about broadband and lack of availability in rural areas, but then that feeds into Jan's question about, do we need brick and mortar facilities for some of these things? Like, since I've been, in the research space the last 15 years, telehealth and, the Project Echo in New Mexico about being able to deliver services without someone physically being there has been touted as a solution. And how do you, either of you or both of you, see that helping, and does that feed into structural urbanism? Do we actually need brick and mortar things for everything in rural areas, or can that help address disparities?
I'll only say one thing, Alana, and then turn it over to you, and say that the biggest problem with that is, I'm going to hold up a phone. No signal. The shortfall, to me, that is a potential solution for psychiatric consultation, for follow-ups, for things where you don't have to actually poke the patient. But we need broadband first, and we don't have it. Alana?
I was going to say, one of the things that we are looking at in how we are categorizing rural is looking at the contribution of broadband access as being a differentiator between those that have access versus those that don't. So I think broadband is going to continue to play a greater and greater role in the actual healthcare piece, but I think it's also going to help define those who have access versus those that do not.
Yeah. Okay, and then another question from the audience. Actually, I have the name. It was Yvonne Macias, if I'm saying it right. And this is always dangerous to ask in a rural talk. But she asks, she knows the definitions can be complex, but she thought it might be useful to briefly review kind of what is meant by metro, non-metro, rural, urban, and then also a lot of the data was presented at the county level. And I'm originally grew up out west, where we have counties that are almost as big as some states, or are bigger than states.
Bigger.
And there can be a lot of very bigger, San Juan County, bigger than Delaware. How does that play into kind of the data you presented?
That is a great question. In our next session is going to actually talk a lot about data issues. So I will give you a teaser for that. But I will say this is the challenge that we have, is that a lot of our definitions on rural, we just completed a paper and we found that some of the definitions that we're using started in the 1800s. When you start thinking about the infrastructure of the 1800s versus what we have now, it's very challenging. In your comments about counties, I live out in Maryland now. Counties here are much smaller on the East Coast than they are in the West. And so when you have counties in the West that are as large as this entire state of Rhode Island, it's really hard to compare apples to oranges. But, for the most part, what we often look at is a cutoff of about 50,000 when we're looking at counties. Counties that have less than 50,000 are usually categorized as rural, and counties with over 50,000 are categorized as urban. However, I will say I have been in some national discussions with policymakers where they started looking at anything greater than 500,000 should be counted as urban, and anything less than 500,000 should be looking at rural. Well, that gives a lot of variability in the kinds of infrastructure. And I think in many respects, the size of the communities and the actual demographics of that community in terms of population per square mile has a lot more to do with access than the actual county definitions. Jan, what do you think?
I agree. I agree totally. The 500,000 thing made me want to gasp and grip my pearls. One of the things that I'll point out, I think in solving structural urbanism, one would have to decide what a community was and what it needed. And I'll point out, we do have some mechanisms, like we have HPSAs, health professional shortage areas, where you count, it's a mixture of population health, and the providers available. And even those definitions tend to be contentious. But like I say, as Dr. Knudsen pointed out, there'll be another presentation that'll go into some more detail about this and perhaps keep our listener happy.
Okay. Another question from the audience that I'll reframe a little bit is, so we talked a lot about rural kind of places and the people that live there in terms of like demographics and, you know, the age distributions and such, and disease burdens. But there's also a cultural element to rural. It's, you know, for fair or not, people tend to think of rural populations as more kind of self-reliant, and there's a thought that maybe they delay healthcare because they just want to take things on themselves and see how it works out and not have to go to the physician until it's too late. Have either of you picked up on that in either your personal experiences or your research, and whether or not there's kind of a rural culture that might contribute to health disparities?
I'll take a first shot, and that'll give a lot of more time to think and say something smarter. And my first shot is, there is not one rural culture. Hello, hillbilly elegy, bite me. There are multiple rural cultures depending on place, but there is such a thing as travel impedance. Because I grew up in a rural area, and trust me, we did not run to the store just because you ran out of one thing. Because it was such a long ways to go, you waited till you actually needed something. And I think part of what is people see as a culture of individualism is a mixture of people having to pay first dollar healthcare because they've got high deductible policies if they have insurance at all, knowing how far they're going to have to drive and is it worth the trouble. Maybe it'll go away if I wait a day or two. So I think there are presumably different cultures, but there is also the literal on the ground barrier of how far it's going to be.
The only other piece I would add is that historically, rural residents have had a lower rate of insurance, so they've been more likely to be uninsured. And I think having that proximity, I think there is something to people knowing each other, and people do not want to carry debt and owe anybody money. And I think that oftentimes when people have decided to forego healthcare, it is a financial consideration every bit as much as it is a cultural.
Yeah.
Okay.
Just great answers and great questions. Unfortunately, we're actually at the time I need to transition to the next session. I wish we were in person and had a way of like clapping for you, because this was both great. Yeah, hug yourself and clap, because those were both great talks and great questions. I know I could keep talking about this for a long, very long time. So thank you, Jan, and thank you, Alana, or Dr. Probst and Dr. Knudsen. And in terms of people in rural areas being more general and having to cover a lot of ground and do multiple things, Alana is actually moderating the next session. So speaker right into moderating. So with this, I'll hand it over to Alana, who will introduce the speakers for the next session and moderate.